Aku macam kau on 2 source tadi aku dengar.
Tu lens.
Lens ni mic ni kau kena off. This one. Sebab kau kan guna ni untuk capture kan. So ni double. Ni mic PC kan, mic auxiliary device.
Sebelah atas sikit. Sebelah atas.
Stop audio.
Stop audio dah off.
So tu cuba tengok lagi
Okay, tolong
ni letak ni ke?
Tekan je.
Ni.
Tekan je. Okay. Speaker ke belakang lagi. Sebab nanti nak apa, macam tengok audience sikit. Morning, ada slide yang you nak present tak nanti?
Ada.
Boleh saya
pakai komputer saya ke macam mana?
Boleh, tapi ni untuk live streaming saya nak.
Live streaming. Okey.
Ada ni tak tambah?
Ada.
Pinjam. Tak kena tambah slide. Tak ada apa kan? Nak copy start.
Boleh. Tak ada apa. Just add in je. Just copy and paste.
Technorad. Mana Technorad? SP ni ke? 97. SK.
Yang tu
Yes.
Latest advancement
Yes, copy that shit.
Ali boleh bantu dekat lift kalau dekat lift Asyik kasih sebab banyak orang yang itu tak nanti sebab dan start
ni sebab dekat bawah tu sharp standby ni sharp standby ada
On the way.
sharp standby action lagi tu tambah bawah. Just press je. Just dia akan terus kan.
Press je.
So we add the breaker lagi.
Tak salah.
Lagi.
Yang ni 400 apa yang yang dah boleh pakai biji ni. Okay. Aku dah buat. Okay. Kerja Asher pula.
Slide yang kau combine jadi make sure kau save. Kalau tiba-tiba apa-apa whatever kau save kan. Save somewhere, I don't know. Macam file.
Kenapa pula ada problem ni?
Yalah, bila nak actual benda save kan? New one, this 1.1. 1.1. Okay, save. Dah hujung. And error occurred berapa saving the file. Lampau rapat.
Biar, okeylah macam tu.
Batu dua.
Okay.
Need my help?
Aku dengan Asher tu. Jom kita jumpa Cik Ahmad. Ni dah start live dah ni. Biar.
Tak ni backup untuk phone.
Oh.
Sampai.
Apa ni?
Switch lah. Okay, also.
start in about 5 minutes. Just to see.
It's a 2-hour flight. So we'll just fly one straight.
Which university are you from? In Netherlands? Leiden. Leiden.
Thank you.
Where backpack is the middle section with free. Yeah, this
Already some of the video.
okay.
Yes.
They have to since
You want? Is it from what? Because from.
let's see. Once they
Good morning, everyone. Welcome, everybody, and thank you very much for joining us here today. I see some familiar faces, not too many because I have to take my glasses off in order to read my paper. Who was Saturday at our presentation at the MCOR? I see a few hands. Can I see some hands? All right, so there's a number of people here. Today we have definitely more time during MCOR. We are going to miss the professor's, very lively professor's presentation this time. But we have a few presentations today. We have a presentation by ADCT on the NUVU. Then we have the user experience presentation from Dr. Martin Wasser from the University in Leiden in the Netherlands. And we also have a presentation by Salvinder Kal, who might be known to most of you in the audience here today. And outside we also have a Technorad partner, SOT outside with an ultrasound demo unit. So if you want to have a look at it during your break, please mingle and feel free. So I will start to mention, sorry, that's not me, I no longer need that. As we continue to explore advancements in healthcare technology, we are thrilled today to introduce you to a groundbreaking development in breast scanning equipment. This German technology represents a significant leap forward in early breast cancer detection. Its advanced imaging capabilities enhance diagnostic accuracy, and with no breast compression, it ensures excellent patient comfort. During the presentation of Dr. Martin Wasser, you will clearly see the differences between the different technologies and how the NUVU comes out in comparison. So we are honored today to have a very special guest who flew in from the Netherlands, my fellow countryman, and I'm from the Netherlands, but I've also been in PJ for 27 years, so nearly Malaysian. So we are honored to have him here today, and he will present the technical as well as the clinical aspects of the world's first spiral breast CT. It's called NUVU, and NUVU is also approved by the Malaysian Medical Device Authority. To bring this revolutionary equipment to healthcare providers in Malaysia, we have partnered with a distributor, Technorad, which is a leading distributor known for their commitment in quality and excellence in medical technology. I would like to introduce the CEO and one of the co-founders of Technorad, Mr. Manjri Manan, who will give an introduction of Technorad Sindhu Bahat. Please welcome Mr. Manjri on stage.
Stretch it on. Maybe the mic.
No, it's not.
Thank you, Madam. Okay, first of all, Assalamualaikum warahmatullahi wabarakatuh. And good morning, ladies and gentlemen. I would like to express my appreciation and special thanks to Dr. Zahuri on welcoming Technorad to join organizing this ADCT talk. Special, but she's not here today. One Erina, the physicist of Hospital Putrajaya, on helping us to make this talk, to be able for everyone to get sharing points, and the whole the pengarah of Hospital Putrajaya herself, being the only partner of this talk. And I would like to welcome every one of you to this important workshop about the groundbreaking technology, which I believe will shape the future of breast imaging. And not to forget, its goal in detecting cancer at early stage as much as possible, saving life of many mothers, wives, and sisters. But before that, allow me to introduce Technorad to you, a company which carries the responsibility on giving assurance that this new ABCT technology will be working excellently in your hospital for its long lifetime. Technorad today has reached to its 6 years since 2018, operating as a complete biomedical engineering service company. At this moment, I can assure you, no company in this country are able to do full total biomedical engineering equipment maintenance from a general biomedical equipment to the highest end like CT, MRI, and radiology. We are the only one. But on top of this servicing, we are now operating as an AR, authorized representative, and sole distributor for a few brands of radiology imaging system, which we identify unique and has its own ability of shaping the future of imaging. First, let you know that we had been in since 2022. For me? Okay, since 2022, we managed to bring in these unique products within a few months. We had taking orders for more than 10 units. The first system that I would like to let you know is our mammogram system. Maybe you can tell me. Viola DVT, which has all the technology of today's mammography, including CSM biopsy. But on top of it, no one in today's mammogram manufacturer are making this system to be able for the doctors, for the user to perform biopsy in either prone or sitting. And now you are seeing our unique fluoroscopy system, which gives the true meaning of multi-purpose fluoroscopy. Opera swing by GMM from Italy. A fluoro machine which has all the radiology, fluoroscopy, and angiography. A full-blown machine which has digital X-ray function, which is greater than what we are having today in our hospitals. It has all the auto stitching, sending a spine, dual exposure, dual energy exposure for bone and tissue, bone and soft tissue suppression. And through its ergonomic tube and detector design, it allows zero patient movement, which is good, also good for trauma center. And for today, we are about to talk about advanced breast CT, which they are only AV advanced breast CT with spiral CT technology and photon counting detectors. It's revolutionized for me totally the breast imaging. I know, inshallah, very soon we will see this machine in my previous 2 slides to be the install base, healthy very soon, inshallah. But ladies and gentlemen, I have said this and I would like to repeat this again and again. I have strong belief that all these good products must come with good best service solution that we can provide. And here is Technorad, which we have structured our company to be the best service provider, and we identified these essential values in our people's competency, technically and clinically, and our customers-oriented service strategy, which I can say, we are the only company operates 24/7, 365 days a year, covering your system for breakdowns anywhere in this country, and our strong logistic support to ensure you will get the parts within days and not weeks or months. And we are enriching our local spare parts inventory to minimize downtime. If possible, if you have a parts that need to be replaced today, you will get it today through our local inventory. This is what we are working for, and we are continuing, to be better. And to end this speech, I would like to show you our corporate video, which extensively helping you to visualize my words. Thank you for your attention.
Technorad Corporate Video. Starting in 3, 2, 1.
Welcome to the future of biomedical innovation, where we revolutionize healthcare through cutting-edge technologies and groundbreaking research here in Malaysia. Today I invite you to join us on a journey for the incredible possibilities that lies at the intersection of science and humanity with Technorad. At Technorad we offer total healthcare solutions with high standard of service quality. We are on a mission to improve lives and transform the way we approach medical solutions by giving various types of services with a passionate team of experts and state-of-the-art facilities that extend beyond conventional boundaries. Strengths like having access to genuine parts of biomedical equipment from multi-types of brand, having 24/7 hotline service and 24 hours left time of inventory will help you accomplish in many ways you will need. We provide edge-cutting biomedical products from enormous companies in the biomedical field, such as United Imaging, including MRI systems and CT scanners. We are at the forefront of biomedical advancements and extend beyond conventional boundaries. There we have products from China and Korea. They have all the advanced equipment and systems, including the mammography system, fluoroscopic system, mobile radiography system, and digital radiography system. Technorad also supplied the world's first dedicated CT scan for breast, ABCT, which is made in Germany. Moreover, we also have ultrasound from Focus Fusion. We collaborate with leading medical institutions, universities, and industry pioneers worldwide, adapting interdisciplinary partnerships that propel innovation together. We are breaking down barriers and pioneering solutions. Not only that, we also build and design. We provide integrated design and construction services for healthcare facilities. The company is moving towards succession and delivering high quality, innovative and cost-effective design for its clients, including clinics and medical research facilities. Operation
Otherwise, I'm in duo stereo. We are doing a little bit of program this morning. We have another German guest who's flown in from Germany, and it's Mr. Oliver Dietrich from ADCT in Germany, who is the owner and manufacturer and the developer and the R&D behind our new view system. He's going to do a quick presentation on the overview of new view, and I would like to hold your questions, as I think most of the questions will be answered by the presentation of Dr. Martin Wasser. And during his presentation, we will have open floor where we can ask questions and we have a bit more of an interactive session. So I would like to introduce Mr. Oliver Dietrich, who is Chief Marketing Officer of ADCT India.
Sorry guys, I think we're going to try to dim the lights a little bit so you get a better view. We're going to find the light switches, which is...
For this time to introduction. And hello everybody. The next maximum 45 minutes, I give you a warm up for the presentation of Dr. Martin Wasser. So we want to give you that introduction to the company, the product, technology behind it, and then Dr. Martin Wasser, as mentioned by Rajan, will answer all the questions. At least he will do his best, as I know. So who's ADCT? ADCT is found back in 2016 by Professor Vitalina, who is this guy. He's the inventor of the spinal C, and as mentioned as well, ADCT was found back in 2016. Got CE mark for the product in 2018, and got the first installation as well in 2018 in Zurich, where the system is still running and the after replacement. ADCT is around approximately 50 employees at the moment, and we are based in Kelab, which is Romania. It's the north of Bavaria and Germany. Which is, as I said, nearby Munich. Sorry. So, we all know breast cancer is the most common cancer in women. And this is across the globe. Numbers vary a bit, but here's one thing, this is what we found out or looked at this, and you probably know it. The mortality rate here in Malaysia is 56% higher than around the globe, which is a bit concerning. And the reason could be, or what could be done against it, is early detection. We all know that. So, and here on this side, this is Dr. Boss. He was one of the users in Zurich, and his experience is, and these numbers, they're almost the same. They said, where we have a screening program, and all over Europe we have a screening program for all the ladies, they get an invitation letter, and only around, this number is for up to 46 patients, only 50% of the invited ladies show up for the screening. The big reason of that one is, which is here with the 46%, is this is because they say it's because of the pain, they're concerned they have with it. Which is obviously contradictory to that one, early detection. I want to work with half of them show up. And the latest numbers I looked up in Germany, the 50% went for the screening. For the second time, only about 25 to 30% drop what again. So it was a very limited number, and it's quite concerning number. Our neighbors from the Netherlands, there's a lady, she's very active because on this side. She said it can't be like that, so she is very convinced about this technology. She started an initiative, a petition, and she made 95,000 women within a relatively short period of time to sign up. And she made clear that she was invited to present to the top in front of the parliament. So now is the board is the core of the parliament or of the politicians, and we know that can take a while. But they're quite active on they're willing to promote this, to get this pain-free technology available for all the needs. So there must be a solution for that. And we believe for MCT that is this system, because this comprises everything we just heard before, in which I will talk you through in a minute as well. So the lady with a crown on the system is on the whole, the body rest in the hole. They can use here a sandbag in order to make sure the post goes in to help the lady that she's like there. And basically there are too many requirements about it. There's some stairs you need to walk up to the system. Then you have a kind of mobility that you can lay down. As I said, we call it superwoman position when you lay down. So you have to have your neck a bit elevated, as more or less that's it. Okay, good. So let's have a look inside of the system and on the top. So we have this ergonomic formed shape when the patient is on it. But I think the whole thing is very inside the hole. So we have our X-ray tube on this side, which is focal, has a 0.4 focal point. We have the photon count detector, and this is a different one than the others, which is the curve, and that makes the difference out of it. And this combines the technology and the software. And then obviously, we have here the gantry, which is spiraling down. And the examination, the average is between 7 to 12 seconds. That's it. Then we reposition the patient, another 7 to 12 seconds, and it's done. And during this examination, we can generate up to 12,000 images. And you're going to see what these 12,000 images mean at the end of the day for you.
Yeah, when you get closer to the mic, so it's clear. Yeah.
Okay, so really.
Thank you.
So have a look here. That's the way it looks. Usually it's obviously closed. The gantry is spiraling down. As I said, 7 to 12 seconds, depending on the breast size. And then it's done. As you can see here, obviously there is some, let's have a limitation. There are some restrictions. It's with 16 centimeters, which should not, the breast size, maximum 16 centimeters, should not protrude out of here, because obviously we have some moving parts, and this could be very dangerous. But there's a positive but. If you have bigger breasts, you know, some of them are users, and say they make the lady using a white shirt, or a sports bra without backing. And that works. So we have them can look at bigger breasts on the system. So what is the photon counting technology? We have on the left side the standard clinical CT, and the main difference out of this to the medium, to the photon counting technology we're using is that we're converting the signal right away in an electrical signal, and not just going from light first, then on the electrical, then we convert it. So we're not losing indicators, we keep all of them, and then we generate the sharp, precise images, which I'm going to show you in a second. Just a few of these specs around here. The X-ray tube is 60 kilowatt, and the focal size, font size is 0.4, which is important. As mentioned, on the spiral, we generate about 2,000 images, or up to 12,000, depending on the size. Pixel size of the detector is 0.1 millimeters, and with our reconstruction unit, we get full 3D high-resolution images. So summarizing on this one, I think very important I was pointed out down here is really for the ladies. There's no compression, there's no need of touching the patient, and there's a short examination time. So it's available the same day, the lady doesn't have to go home, so more or less after she's dressed up, the radiologist is available, they can go through the results, and there's nothing to wait on. So then they can really decide right away what is the next steps. So not coming back next week. We have this real 3D imaging, high resolution, and of course, as we go circling around, no superposition. The radiation dose is comparable to the mammography, and because of the use of the cutting-edge photocavity technology. So let's look at these modalities here. We have the mammo, tomo, sono, and MRI. Fortunately, with the breast CT, we can combine everything. So we have real 3D imaging, which you don't see with mammo tomosynthesis. Tomosynthesis, from my point of view, is a kind of 3D imaging, and because if you go straight 50 degrees to 50 degrees on the other side, I struggle about this to believe that there's a real 3D imaging, but yeah, some clay data, so to speak. Our system can be used with contrast, but we don't have to use this contrast medium. And with our system, we definitely will detect microcalcification, so the cluster of microcalcification, as you know, this is a pre-indicator for which potentially can develop cancer. And if you combine all the other systems now, apart from the sonography, I think the comfort for the patient is the utmost we can give there, because no MRI going in there is not comfortable at all for 30 minutes. And for mammo and toe, I don't need to mention. The squeezing, pulling doesn't make the ladies feel comfortable at all. If you look at the indication of the contraindication to mammography, this is one thing we use. Further clarifications of the microcalcification with the contrast media. And one of the contraindications, we know there's pacemakers around, or maybe prosthesis and all this stuff, that or contrast media allergy, then we could use with the system. So let's have a look around here. What are you going to see when you use our system? Well, we see the skin, we see the adipose tissue, we see the glandular tissue, and in a second we see the nipple as well. And here is what I like, because we get often asked because about smaller breasts. And as you can see the ribs or the pectoralis muscle, then obviously you can do almost, there's no limitations as size, small sizes. You can see lesions here. And one very interesting segment as well, we can look at implants. And, this is something for post-op stuff. I think it's very interesting for certain countries, certain cultures, because for squeezing an implant, who's knowing what you're going to do that, is not very good. So let's compare here. We have, this is the same woman. On the left side, we have the mammography. You see here the spots where there could be a microcalcification cluster. You probably see them better than I do. But therefore, it is easier for me on this side. If you click on it, you can scroll through it. And now you see the microcalcification cluster here. And the same on this side. So even I can see it here clearly that here's something going on. We should have to do it, should monitor. And here we have same breast, one pre-contrast and then one with post-contrast. And let's go through this as well. Well, the pre-contrast, you already can say there's something going on. But if you look at this contrast media, you definitely know there's too much things going on. Here we use a nice and interesting technology. There's a volume rendering technology, which is, I think, what is it for the surgeon to do the planning? But as well, I think it's good that if you talk to your patient to explain really what's going on, it makes it much more understandable. And for the surgery, I think as mentioned, it's really you see all the vessels, you see all the tissues, and then you will probably use the exit point, which is the most or less traumatic than others. And so with this technology, no surprise for the surgeon at least, because you can see, you can plan, you get the sizes, the measures, and what is needed. And then you can turn it around and see it from very different angles. Here's one case, it's an extreme case, I have to admit. This was from one of the users out of Dortmund in Germany. He went with the lady, not on purpose, kind of purpose, but he was looking at all different modalities, as we've written up there. He looked at mammography, he looked at tomosynthesis, he looked at ultrasound, and even MRI. He was suspicious that he was seeing something, but he was not proving, am I wrong, am I right? So then he used the breast CT, and this week he saw on all the other ones. He found all the other ones. This small one, he found out and confirmed his suspicions with the breast CT. Rare case, because usually you not run through all the modalities, but it happens here. And I think it was the benefit of the patient, because if you fall behind them when you're treating it, not a good thing. Then you come back for the follow-up then. So as mentioned before, we can do a look at implants. We have here a nice one, everything is nice. Looks good. And on this side we have one. The whole implant is calcified. So I was when I looked at the first image, I was a bit worried, but I said okay. And we have to go back a bit. So I was worried, but I was explained, okay, that's not a good concern, that could happen. But here we see there's a defect in the implant. And the most thing why I'm showing this, and the doctor said as well, if you went to, let's say, do a tomosynthesis with this implant to try to do it, the risk to really rupture this implant would be very high. So he was very happy that he could do it with the breast CT, so I saw it. And yeah, that's the thing, when you have the modalities available. And then we have here another implant, which looks, to see for the patients or the ladies how it could look like. I leave it up to you how to decide if it's nice or not nice. I would not feel very confident in this my statement to that. And here's what, this is not my statement, this is one of our users. He said in a way, for him, it's a one-stop shop. He gets everything, he says enhanced invasiveness, he gets the microcalcification, he gets scars, he sees everything. So he doesn't need to do all the other stuff. He's very happy about that. And we said, and all in 3D, real 3D. This one, as I mentioned, the guys or the ladies in the Netherlands quite active. And this is when Dr. Wasser in his institute, or the University of Leiden, started with the new system. They did some kind of PR, but this got right over the top. I think the telephone system broke down and they had to shut it off for a while because there were so many inquiries coming in from ladies who wanted to use the system. That's one. And he was one of the main users, and he was the guy who made the statement. Dr. Carsten Ritter from Dortmund. He said for him it's one-stop shop. He's using it on a regular basis, the system. So what is next around? Obviously, we know aware that there's something still missing, what we need to do, or we need to get. So the biopsy option with the system will be around available in Q2 next year. Which doesn't have to say that you have to wait for it, because the systems will backwards upgrade. So if you want, you can take it now. The option that is available, which just can upgrade the system. So there's no limitations, and you don't need to wait. As well, we look at something at the moment, or we start looking into it, because we got more and more requests about it, the mobile solutions around. So this is one example. We looked at it, at a truck, how to get in. So there are various options and around. We're still evaluating which one to take, what is the base requirements we have to meet. And then a couple of other tests has to be done, but this is a project which is ongoing as well now already. And availability depends a bit. But as the system is around, trucks around, we just need to find the right one where we fit in and where we make it happen. Yeah. That's it for the moment. I said we can summarize here. 3D breast imaging without superposition, which I think is great and it's very important. No surprises. The high resolutions of microcalcification lesions. Some per patient comes forward. I haven't experienced it, but I believe I have some around me and we can get some feedback on that. I think there's no short exercise times. It's not to tell the patient come back next week, which I think is horrible. We have a lot of patients at those, and we can use puncture imaging by using contrast medium. As I said, you can and you don't have to. Thank you very much.
Thank you very much, Oliver. Again, if you have any questions, keep them. And during the session of Mr. Martin Wasser from the Netherlands, you can ask your questions. I think we're running a little bit late for the break. However, we're going to start with Dr. Martin Wasser for a presentation on technology. Dr. Martin Wasser is my fellow countryman, and he is a breast and abdominal radiologist from Leiden University Medical Center in the Netherlands. Leiden is slightly south of Amsterdam. Most people know Amsterdam. Most people do not know Leiden. And I met Dr. Martin Wasser in the hospital where I've actually seen a patient using the NuView, and I've also laid on the NuView to see how comfortable it was, and I'm personally a big fan. And Mr. Martin Wasser is an author and co-author of 130 scientific papers, and we actually met somebody in Malaysia that says, "Oh, I know you, I've read your papers," so that's very nice to hear. And his research focuses on early detection of pancreatic cancer using MRI, and on exploring novel imaging modalities for detection of breast cancer, such as 3D ultrasound, optic imaging, MRI, and of course, breast CT. He has extensive experience with the NuView breast CT system, which was installed in Leiden University Medical Center in October 2021. I would like to, are we ready? If not, I would like to introduce Dr. Martin Wasser. If you have any questions, please raise your hand. I will come to you with a microphone so he can clearly hear you. All right, thank you very much.
Thank you, Earl. Thank you for the very kind introduction. And I'm really honored to present my experience with the new technique to you. It's my first time to Malaysia, and I really enjoy it. Thank you very much for that. So I split my talk into two parts actually. First, I'm going to talk about the technology, which is a sort of the repetition of the previous talk, but I don't think you will mind. So I'm from the Netherlands, Leiden in the Netherlands. It's a very small country, and it's sandwiched between Germany and the North Sea. We're really small, and we are known for our flowers and the windmills and the cities with the canals and a lot of bikes. But since 21, actually, we acquired the NuView breast imaging system. So we installed it in October 21, and this is our room when we installed it. And these are the computers that are attached to the system. We have, so there is an acquisition computer, this is a construction computer, and we also have a scientific research computer to do other things with the system. So this is the procedure. The woman has to climb 3 steps and lie prone on the table with the breast in the hole We put, for the comfort, we put a sandbag on the shoulder and a cushion under the feet. Please, if I'm not clear, if I'm going too fast, if you have any questions, please ask them. I'm going to make it a sort of interactive conversation. Well, it's said before, it's pain-free really, and also important is that it keeps the breast in its natural shape, so there's no deformity, and the extension is fine. It's short, so the woman has to be able to climb 3 steps, and she has to be able to lie in prone position for a short time, and she must sort of have a flexible neck. She has to look to one side. Actually, there are 2 systems on the market that provide the breast CT technology. One is from the United States, it's called Kelab, and of course the breast CT from ABCT. The Kelab system uses a different technique. It's a cone beam CT because it uses a flat panel detector and the X-ray tube that rotates around the breast. Whereas the HCC system is a photon counting system. And these are the specifications of the 2 systems. A lot of them are fairly similar. Well, the most important difference is the use of the detector. Corning uses a flat panel detector and HCC photon counting system. Also, the coning system circulates around the breast and the spiral CT of the ABCT. The diameter of the hole where the breast has to get in is about 20 centimeters, and an important parameter is the length of the breast in prone position. So we have 3 possibilities. You saw the rings on the tube. And, well, we made a lot of images come out of the machine. So this brief repetition of the photon counting system. So the standard clinical CT scanner uses a simulator in which the X-ray photons get converted to light that scatters. And then the light is converted again to electric signals, and by photon counting you just bypass the conversion of the X-rays to the electric system. So that makes it a very much sharper image. You get more energy, and it's a sharper and much brighter image. These are the main advances of the advantage of the photon counting system. So you have smaller detector pixels, you get elimination of the noise in the system, and you can actually measure the energy of the incoming photons, and even very low energy photons can be measured. And you see the difference of the 2 techniques. On the right, there is the paranasal sign, and you see on the regular CT, it's more or less blurry image, much crispier on the photon counting CT, and you also see the difference in dose. The dose is much lower on the photon counting CT. It's a total body scan. Well, you saw the gantry with the X-ray source and the detector. And the system first makes a circular movement around the breast, so close to the chest wall, and then starts spiraling down. And it's more or less a fan beam of the X-rays. You saw it, so the first movement is the circle one, and then it spirals slowly down. This one reconstruction, there is still an algorithm that has to be improved because the reconstructions take some time to make. And because it's such a high resolution system, you can put also other small objects in the scanner that make some very nice images. On the right is the rose, and we put it in a solution of diluted contrast media. So it sucked up all the contrast, and you can see it by the stem and the nerves in the leaves. It's really crispy and nice image, and we'll make a volume rendering image. This is one is a pine cone, and it's really very nice and sharp. I also put my hand in the scanner and removed all the muscles and the tissues, and then you have the bone. You see the clavicles of the bones are really sharp. And maybe you can use it for detecting fractures in the wrist. And we looked at the radiation dose of the system and compared it to tomosynthesis. And what you can see is that it was in about 100 patients. And what you can see is that in tomosynthesis, there's a really large bandwidth between the lowest and the highest radiation dose, and that's due to the density of the breast, due to the large variety in density. Dense breast costs more radiation to image to get a nice image, and you see that in breast CT, the bandwidth is much smaller, and on average, if you see it for 2 images per breast. The average dose of breast CT and tomosynthesis is almost the same. Slightly, on average, it's slightly higher for breast CT, but because of the large variation in breast density, you can get totally different numbers for tomosynthesis, and for breast CT, the variation is much less. This you also saw the different modalities there are. And because, well, most of the functions can be delivered by MRI, except for detection of microcalcification, and it's not a very comfortable examination. And all these good aspects can be met by breast CT. We wondered what would be the coverage of the breast in breast CT compared to mammography. So we attached markers to the skin of the volunteer. I made a mammography and a breast CT examination. And you can see the coverage of the breast is fairly similar. And we see sometimes, or very often, we see a large part of the chest wall. You see the ribs and the pectoralis muscle. So the coverage is very good. And the same as in mammography, it's very difficult to detect lesions, and the breast gets denser, and especially in the very dense breast. It's also with the breast CT very difficult to detect a lesion. And that's why we started to give IV contrast. And actually, in a very large part of the patient image, we use contrast actually. Only in the very fatty, totally fatty breast, it's easy to see a lesion, but the other densities, it's maybe difficult. And if we don't know the breast density from previous mammograms, we always give contrast. So this is our contrast administration protocol. It's the same as in normal CT, and also the same in contrast mammography. So we give them an IV needle. We lay the patient on the bed We start injection, and we wait for 70 seconds. And after 70 seconds, we start returning the left breast. And then after 12 seconds, the woman has to change, put the right breast in the scanner, and then we do the second scan. Total duration of the scan, including contrast injection, is 2 to 3 minutes. If you compare, because of the new technique of contrast enhanced mammography, the contrast administration is the same, but for the contrast enhanced mammography, you have to make 2 mammograms, a low energy and a high energy image. You subtract them and then you get the image. So we do that, you have to do that 4 times. So in total, the total examination time can be up to 10 minutes. And the disadvantages of the contrast enhanced mammography are, of course, the longer examination time. You also need to give a higher radiation dose, and of course, we still have the compression. These are the images you get from the contrast enhanced mammography. So you have the low dose image, it's the normal regular mammogram, and the high energy image is enhancing breast lesion. So what happens if you don't give contrast? Well, you can get these kind of images. You saw when you see some masses, it's a little bit fast. I'll repeat it. Here you see some nodules. But you have no idea, is it a true lesion or is it not? So then when you give contrast, you get much more clear. Here's again enhancing lesions, I'll repeat it again. And here's a large one just behind the nipple. This is also visible on the ultrasound. So it's although the dense is not particularly dense, the breast is not particularly dense, it's still very handy to give contrast. So we do that in almost 80% of all examinations nowadays. And these are the images that you get from the scanner, so that it makes the native reconstruction in the coronal plane of 0.15 millimeters. That's what you get from the scanner. You can also reconstruct large, thicker slices of 0.3 millimeter, but we always use the thinner slices. But we are not satisfied with only those coronal images, so we make reformations in a different program. We make reformations in the sagittal and axial plane of 1 millimeter. And recently, we started use another program. We make a MIP, maximum intensity projection of the entire breast. And then you get these images. You squeeze the total information into one image. And it actually is a 3D volume, you can rotate it, but we standard make projections in the sagittal and the axial plane. And it's like if you shine a torch through the breast, and all the structures with high density get lightened up. And so you see the vessels, you see enhancing structures in the breast, and non-enhancing tissue stays in the background. And then what you then get is a sort of a mammogram that looks the same. This is the sagittal projection of the 3D volume there. And when you rotate the actual image, it becomes a CC image, and then you compare it. And in this case, you see a clearly enhancing mass in the left breast out behind the nipple. You can look at the individual slices and go through them, and you see clearly the rim enhancements of the lesion. And then we look back at a mammogram that was 7 months before. And actually, well, there's not much to see. But if you look back, maybe there was maybe a small mass visible here. But it's much more clearer, although there is a time difference of 7 months, but it's clearly visible on the breast CT. Another case of a dense breast. On breast CT, you see a small enhancing nodule closely in the right breast, and also on the individual slices, it's about 5 millimeters, which you totally do not see on the mammogram. So that's the end of this part. I think it's time for break now.
Yes, I think actually a few people at the front, you might not be able to see the full images, that's so. Maybe after the break, move, because there are several spots still available throughout the classroom. And so maybe sit somewhere else where we can get a better view.
I'm standing in the way.
Yes, so from here, it's sort of... do we have any questions or any thoughts that we want to discuss before we go on tea break? If so, can you please raise your hand?
Yes, please.
Good morning. Thank you for the lovely presentation. I must say the images look very beautiful, but my concern is the radiation dose. 6 milligrams per breast, isn't it?
No, the 2 breasts.
For both?
Yeah.
Oh, right. Because
the total examination of the tomocystis compared to the total breast CT image. It's the same.
Right. And what about if you just say if you realize that the breast is dense? What is your experience with the small spiculated lesions in the dense breast? Because I saw they appear to be very homogeneous and blending in with the breast parenchyma. What is your experience with that? And small groups of microcalcification.
Yeah, well, I will have lots of...
right. Okay, so that's another one. Okay, so another thing is, so when you actually give contrast, you have to scan again. So
no, actually, no. When we, most of the time we have previous mammograms of the ladies, and we know the density of the breast. So if it's a completely fatty breast, we don't need contrast. And in the class C or 3, so the intermediately dense or completely dense breast, we always get contrast.
As a primary imaging.
As a primary imaging modality, and then we have the scattered fields of breast tissue. Some of that we call it a small B or a big B, and if there's much tissue, breast tissue, then we get contrast. And in some cases we don't know the density of the breast because you have never had a mammogram before, and then we always get contrast.
Okay, so the ones who had no mammograms done, they get a direct contrast.
Yeah, because otherwise you would have to repeat the examination.
So basically, you need 2 rooms in your center. One is for the CT, and one still for your mammogram for the patients who can't go onto the system. So you have to have two rooms for this procedure.
Yeah, because we still do mammograms in the mammography. That's still the normal practice. So it adds up. In our hospital, it's added up to all the other examinations. We also do MRI. We do PET-CT. We do mammography. We do ultrasound. So it's at this moment, it's still in addition.
Right. So I'll wait for your second part before I ask the rest.
Okay.
Thank you so much.
Good morning, I'm Dr. Zabrin from Putrajaya. Just wondering, meaning that you use the system for both diagnostic and screening at the same time, or you mainly use for diagnostic? Because you have your mammogram, you have your ultrasound and MRI, together.
Yeah, well, we have in the Netherlands we have a program of population screening, but not in our hospital. That's separate. So all the
Mainly for the assessment in
right,
assessment cases, right?
Yes. And also because patients who have an operation, they still keep coming to our hospital to follow up.
Regarding the contrast, how much the contrast sleeve, and what sort of concentration that you use?
It's the 450, I think. It's the non-ionic.
Oh, 450. Yeah. 370, no. Because for CM we use 470.
That's true.
Slightly higher concentration. Or is it the normal concentration like some?
Yeah, big blocks.
300.
Yeah, it's 350 or 400.
For us, it's meant cost.
Yeah.
More concentrated, higher cost.
Yeah, that's true. But it's the same as in contrast therapy. It has not really figured out which concentration you have, how much you have to get. So it's not entirely clear.
If you have less concentration and less.
Probably.
Yeah, because kidney, one thing is for the protection of the kidney, and another thing is cost.
Right.
Because I know some, I think for pediatric, you have this low dose technique. For you have the software, right? Whereby you have to choose within your initial diagnostic value and amount of dose that you want to apply to the patient. So I think since breast is a radio-sensitive structure, and you know that CT usually gives higher radiation as compared to the air. So because doing assessment is okay, but when you want to plan for the next training for your biopsy, for your so I think you have to need to consider the dose concentration there.
It will be lower in the future, but it all has to be. But it can be pretty fast. Developments are very relative.
Thank you.
Any more questions before we go for a cup of tea and a cup of coffee?
Hi, I'm Dr. Nasina from Putrajaya. I'm just wondering, what's your tentative plan to do biopsy? Are you going to compress the breast as well?
Well, you have to fixate the breast. That is it. You don't have to compress it, but it has to be.
Is it kind of MRI?
Yeah, it's really comparable to MRI, probably, because then you also do not do very tight compression. It's just fixation of the breast that it doesn't move when you start doing the function. So that's the main thing you have to consider. The breast doesn't move.
I think you still need the breast.
Yeah, but it's just several possibilities, like for instance, an airbag system. But probably you need a grid.
So the patient will stay in the same position as when the scan patient, isn't it?
No, it doesn't have to be in the same position. Because I think you will not do it immediately after the scan. Because then the period is too long, probably. So you reposition the patient, but it's fairly comparable in different scans. Because the breast can hang freely in the opening. There may be a slight change in position, but the location of the tumor will be the same.
Thank you. Sorry. May I know why, when you plan for this research, why do you choose tone rather than line supine?
Then the position of the breast is completely different.
Because I've done biopsy with patient with CT supine position. Because we have cases in Malaysia, so many with venous injection, silicone. So sometimes it's very difficult to do. You can't see on mammogram, you can't see on ultrasound, and MRI, we don't have an MR guided biopsy. It's very expensive. So we've tried with CT before, and we get it. So I think, yeah, because you want the most issue to be there, is it?
You can see it with the ultrasound.
No, silicone. Yeah. This is free silicone injection, it's not silicone implant. I think you will never see that in your
No.
We have so many silicone color acid or so many things being injected in the brain. So it's a really headache for us. These are the young ladies. Yeah, it's for aesthetic. Yeah.
But what's the system in Kelab? So within the spinal system.
Why do you, in the first when you plan, because you think that you in your prone position, most of the tissues, because in my center we don't have a mammogram, so yes, I agree with you see more lesions on the CT. Well, I come from previously from the oncology center. We see more lesion and unseen on CT where we try to target with ultrasound because we don't have mammogram in our center. And we do ultrasound from the CT, ultrasound, or sometimes we need to resort to MRI. So I guess because you choose the prone position because it's most issue there.
Maybe we have time for a cup of tea and a cup of coffee and probably some snacks outside, and then we will see you. How long is the break? I'm looking at the Technorad team. Half an hour? Yeah, so we'll see you back in half an hour. It is now just before 11 o'clock. We will see you back in here. Alright, and feel free to mingle and have a look at their ultrasound unit as well, demo unit, and then we'll see you later. Enjoy.
Nog steeds voor, hè? I think put it right back. Put it right back. Yeah, that'll be fine.
Yelah, harapnya macam tu lah. Okay. Macam biasa lah. Biar risau ke kali play ni. Biar kita try convert masuk kat dalam. Tapi tadi dia dapat okey je.
Tak, kau buka guna Google Photos. Buka guna Google.
Apa? Oh,
guna Google.
Tapi Google Photos boleh je play.
Tak. Sometimes certain format.
I see. Biarlah nanti.
Nanti aku
bagi apa boleh ada. I'm proud of my tab. Walaupun it did its job, man. Dah. Lagi kopi ke apa?
Ja, you can see that. It's also a test with an extra lighter. Let's try it. I'm making a switch to install. Lights on this right here. Yeah, because something's also
sharp. Uji nggak berarti.
Yeah, I'll go give this about to board the plane, are you?
train commissioner. We've got the Prime Minister coming, so he is expressed the problem with the Prime Minister. I said, I'm like, I'm New Zealand, I'm New Zealand, I'm New Zealand.
medical department?
Yes, I believe they're outside on the booth.
He's calling you, Abdi. He's calling you.
Kenapa tu?
Yeah, oh, the presentation. F7.
Untuk Fahmi.
Fahmi.
Okay. You're after there's another one section from him, and then you present it. Weh, Gariza. Macam mana? Jadi video nak buat. Dan ni tak ada clear ni. Nanti tapi tak apa, it's okay.
Aku dah try buka benda lain.
Aku tak ada benda lain. Sebenarnya ni stop and drop. Atau
Dia guna lockdown.
ni Nokia stop and drop. Dia tak ada apa-apa additional apps. Masa masuk tu dia kena full Google. So aku kena mana aku dah
Dia record
tapi rekod daripada ni. Rekod memang daripada dia lah video tu kan. From my MP4.
Dan kenapa Google tak boleh?
Tak apa biar. Ni pun kalau yang tu tak ada pun at least live okay. Live okay, mesti rekod juga. Jadi backup je. Nanti aku rekod.
Why not you change your thing?
Kurang aku. Nanti nak Roger ke apa je tak boleh. Unless kalau aku beli satu lagi phone tak apa.
Jom. Aku dah pergi.
Okey lah, macam tu lah. Aku interested juga dengan kau cakap yang bulan ni kan. I think first kali aku akan rasa sebab aku lewat. So second kali aku maybe dapat around 4 juga. So aku nak buat yang bulan ni. Maybe aku nak buat bulan aku kau plan oh itu juga aku tak just nak tak banyak problem 15 Pro banyak problem aku dah tengok banyak satu 15 ataupun 14 dia antara dua variant tu yang Pro
Nanti aku tak sure kat kedai
itulah ada tapi dia 15 saja yang dua gamer 13 it's one of the best.
Welcome back, everybody. We will continue our session with Dr. Martin Dorsett when you're all ready.
And then for ni, aku nak tukar bateri, aku nak tukar kamera tu,
The coffee has energized everybody again. So we'll continue with Dr. Martin Dorsett. And again, if you do have any questions, please raise your hand on the microphone. Maybe we can stop internal discussions.
Mesti ada kan?
Ada
Music.
Mestilah tak ada mahal sangat.
Technical team, are we in charge of music?
Music. Mana Fahmi?
Alright. All quiet, so we will continue our session and feel free to ask any questions and I will come to you with the mic. Alright? Come over here, you want to yours?
Ya. Hah? Apa dia? Sebab dia takut terus. Tapi rekod nanti aku try semua.
I hope you can hear me. So we continue the session with showing you our experiences with the new technology. So just a small repetition. The normal images that come out of the machine are the native reconstructed.
Yeah, it's a bit annoying.
The very thin 0.15 millimeter slices in the coronal plane, so we reformat them and set to an action plane and make a volume image. So a limiting factor for visualization of lesions in the breast is not only the breast composition, so the density of the breast, but just like in MRI, it's also important to look at the normal enhancement of the breast, because that may interfere with the visualization of levels. And in our reports, also on breast CT, the same as in MRI, we report the density and also the amount of breast background parenchymal enhancement. So in this case, in the mammogram, it's not a very particularly dense mammogram, but still you can see all those small enhancing dots in the rest of the breast. And that's the same as we see in MRI, also the focal enhancing noble portion of the breast. Now another case, which is in a very dense breast, and you can see the density of the breast, but only slightly enhancing focal lesions. And this does not really interfere with the imaging enhancing nodules. But if you don't give contrast, you will see nothing. Another case of dense breast, you see more nodular enhancement of normal breast tissue. They look very almost similar, actually. There are small dots. It's not really mass, but small dots throughout the breast. And the worst case actually is very dense breast with diffuse enhancement of the breast tissue. And even in that case, you're able to visualize a lesion. Mostly in the left breast, you see on the volume image, you see small enhancing lesion, which is better visible on the individual slices. So if you have dense breast, we first look at the volume maps, but then go through the original thinner slices. And this turned out to be an invasive carcinoma. And this is a very interesting paper. It's very recent, in July, beginning of July. So these researchers, they examined 90 patients with 105 malignancy. And they assessed the sensitivity of remains perfect, actually. And only in very dense breast it's slightly getting worse. Whereas in mammography, the initial detection rate is good. It's lower on average in the overall population than the contrast enhanced breast CT, but in denser breast it really gets lower. You also see the difference in reader inter-observer variability, which is particularly non-existent in contrast enhanced breast CT. The images are so crisp and really bright, so that it's easy to see.
Matt, just one second. Do you think it would be easier if you use the microphone and use this pointer, like this, and go through it?
Yeah, but then people.
No, I can use that next one. You're going to be split by the feedback, right?
Yeah.
People online can't see that.
Okay. I hope this is okay. So I showed some cases of malignant lesions. They're either hugely dense breast without any abnormality, but on the breast CT is the same day. and this is confirmed with ultrasound in the biopsy showed invasive breast cancer. Another case of a very small lesion you can see on the mammogram. It's very small, both on CT and below. Also confirmed by ultrasound, and it was biopsy, and it was invasive carcinoma, and a marker was left behind. And we did a CT, and you also see the lesion and the marker just in front of the lesion. Another case, dense mammogram without any abnormality actually, and on breast CT saw an enhancing lesion, also confirmed by ultrasound, being an invasive breast cancer. It's an interesting case. This patient was operated for a papillary carcinoma. You see the surgical clips, and this is the volume mid in sagittal direction. It's a frontal view in this case. And an implant, a very dense breast without any abnormality on the mammogram. But on breast CT, you can see a small enhancing lesion. And this appears to be desmoid type fibromatosis. Another case is a patient with an implant. We saw some enhancing plaque just in front of the prosthesis of the implant. Another view we see the same, and we can digitally remove the implant, and you can see the enhancing plaque better, and it's the same as on the ultrasound. This appears to be these areas. This patient had a large tumor in the left breast, and when we had an operation, it was removed. And we, on the first post-operative scan, we saw this. We saw the surgical clips. It's the same patient. You can see from the calcifications, the same location. And there was a new tumor, also very big. This was really a recurrence of the disease very shortly after the operation. We can also demonstrate multifocal disease. You see multiple tumors in the left breast, also visible on the PET CT. Multiple enhancing small irregular masses throughout the right breast, with the transfers and the sagittal view. Some of them were also visible on ultrasound, and you had an ablation, and indeed it became multifocal invasive carcinoma. Another case, also multiple enhancing lesions. Some of them are visible on the mammogram, also some of them visible on the ultrasound, and this also appeared to be multifocal invasive carcinoma. This is also an interesting case. It's a dense mammogram, actually, and on mammography we saw a mass, which is also shown by ultrasound. And there was a second small mass, also shown by ultrasound. We did a biopsy with twice two invasive carcinomas. But then the other side, on the left breast, was slightly denser than the right one. We didn't see anything on the mammogram. You see, there's multiple enhancing dots. This is the background parenchymal enhancement, but it's also more pronounced in the left than in the right breast. But still, we were able to see a mass, mostly in the left breast. Also, we looked at ultrasound, we saw this irregular lesion. This also appeared to be the invasive carcinoma. So she had carcinomas on both sides. The next interesting thing is to look at calcification. Actually, the spatial resolution of mammography is still higher than breast CT. This is you look at that's what we call a line pairs per millimeter. That's the unit for spatial resolution. You see that it's higher for mammography than for breast CT. So in theory, you would be able to detect smaller calcifications on mammography than on the breast CT. However, with breast CT we have the advantage that there's no overlying tissue, so there's much better contrast between background and calcifications. And that is especially the case when you use the volume method, because volume method it enhances the high density structures in the breast. And you can see here, you see arterial calcification, which is much better appreciated on the CT than on the mammogram. You also see the different calcifications also that are visible on the CT than on the spatial resolution of mammography is higher than for the CT, so the morphology of the calcification is better appreciated on the mammogram than on the breast CT. In this case, we saw two clusters of calcifications on the mammogram, also visible on the breast CT. You see that morphology is slightly different on the CT than on the mammogram. But interestingly, we saw no enhancement, so we get contrast. We saw no enhancement, and these appear to be benign calcifications. This is another case with a very small cluster of calcifications. This is magnification view, and well, did not really look particularly malignant. But on breast CT, we saw the calcification as well, but we saw a small enhancing mass surrounding the calcification, and this appeared to be DCIS. Another case of calcifications. No particular mass, it looks like normal breast tissue, normal density. But on breast CT, we saw the calcification as well, but we saw an enhancing mass. We can rotate, maybe you really see that it's a mass, calcification within the mass. And actually, the calcification itself are not malignant. It's the tumor that produces the calcification. So you don't have to look for calcification itself, you have to look for the tumor. We know that MRI is very sensitive for calcification, for DCIS. And not every DCIS contains calcifications. So if you look for enhancing masses, that is what you have to look for, not only the calcification. Another case of calcification on the mammogram, and also on the CT you see the calcification, but also you see some enhancing tissue in the background, and this also indicated the DCIS. This is a combination. On mammogram, on mammography, we saw a mass, but also a small cluster of calcifications more or less attached to it. It's the magnification view. I hope you can see the calcifications. And on CT, we saw the same. We saw the enhancing mass, but also the calcifications, and also some enhancing tissue. This also appears to be DCIS. Please interrupt me if you have questions, or I'm going too fast or too slow. Another case of, a large area of calcification on the mammogram. And on breast CT, so the case of calcification as well, but also a large segment of enhancing tissue in the background. And this also appeared to be DCIS, high-grade DCIS. Another case of gross calcifications in mammography, you see the marker of the stereotactic biopsy. And on breast CT, you see calcification as well, and also enhancing tissue, also a case of DCIS. Another case, we saw in mammography some calcifications, and also possibly in mass. Magnification view, there are some calcifications, but on breast CT you see a very large mass, or it's actually not a mass enhancement, we call it on MRI, a large area with some calcifications. And this all appeared to be DCIS. And so she had an operation in which the surgeon tried to remove all the DCIS, but on the post-operative scan, we still saw some calcification and a small area of enhancing lesion, and this appeared to be residual disease. And this was an interesting study. It's some years ago already. It's from Aachen in Germany, and they looked in 20 women with proven DCAS and did the contrast-enhanced MRI and contrast-enhanced breast CT, and they did the dynamic imaging, so at several time points make images, and they saw that DCAS in all cases was associated with contrast enhancement in all cases, and the degree of enhancement was similar in breast CT and MRI. So it looks at breast CT has approximately the same sensitivity for DCIS as MRI. So that's why we started doing a multi-center study in which we compare breast CT with MRI. Because our ultimate goal is for the first time, we want to replace MRI by breast CT. In case you want to replace mammography by breast CT, you have to prove that it is better, or at least as good. You need a lot of patients. And in the Netherlands, there are only installed 2 systems now, so it's difficult to get many patients to do this study. So we started with MRI. I'm sure I don't have results yet, but I can show you the raw images. You have again a case of a very dense breast, and on the mammography, on the volume that you see the small dots in the background of the dense breast tissue, but there is no mass visible. That's the same on MRI. You also see the dense enhancing tissue. And actually, the enhancement of on MRI is more pronounced than on CT, and that may be related to the contrast agent, because gadolinium in MRI is an extra vascular agent. It leaks out of the vessels, whereas the iodine in the CT remains in the vessels. So the mechanism of enhancement is slightly different from MRI, from CT. Another case is a small lesion, dorsally in the left breast, visible in MRI, contrast enhancement. With MRI, we can also do other sequences, EWI. And since we cannot do a breast biopsy on CT, we have to go to MRI guided biopsy, and this is usually DCS. Another case, we saw some calcification on the mammogram, maybe some small mass, and on breast CT you see 4 masses actually, and it's completely the same on MRI. So the images on MRI look very comparable to those on the breast CT, except that the resolution, spatial resolution of the CT is higher than MRI. So actually you see the lesion better on CT than on MRI. A woman with an implant, large implant, and an enhancing mass next to the nipple, also visible on CT. And we can electronically remove the implant, and you can better see the lesion. In this case, well, not a very dense breast, but no abnormality visible. And on the CT, we see this small string of enhancing nodules, also visible on MRI. We did an MRI guided biopsy, and it appeared to be DCIS and also some invasive tumor cells. Another case, dense mammogram, no apparent abnormality on the mammogram, small enhancing lesion possibly in the right breast, and on the individual skin slice you can see it's a mass of 5 millimeters. Also visible on MRI and MRI guided biopsy was invasive carcinoma. So we can see really small lesions. as well. And in this case, there was a small tumor in the right breast was better visible on ultrasound, and we did a biopsy and took these two markers. And this is the small tumor surrounded by two markers. The markers you can also see on the CT, so they're close to the enhancing tumor, and you see the resemblance of the tumor on the CT and MRI is really striking. It looks the same, but you don't see the markers on MRI, or very difficult to see. Another small lesion on the mammogram, we tilted the CC image so that it make it look similar to the breast CT and MRI. Again, the small lesion on ultrasound, 5 millimeters, visible on MRI, and again you see the mouse on CT with the small marker just in front of it. This is a very interesting speculated mouse in the left breast, but they have no idea how big the lesion is. Of course, it's malignant, but the size is pretty unknown. Does it belong to the lesion? Does it belong to the lesion? You have no idea. And also on ultrasound, because of the post-acoustic shadowing, you have no idea how large the lesion is. And on CT, we saw the enhancing spiculated mouse. And when you rotate, you see nicely see all the enhancing nodules surrounding it. And on the pathology, it was also the same feature was seen. You see the pink enhancing nodule, and it was a large mass of an area with nodular lesions. So it's really corresponds. It's also shown on MRI, but it's much more crispy on the breast CT. This is the case of a large mouse with calcifications, also visible on the ultrasound. You see the calcifications in the tumor. On MRI, we saw an enhancing mass, and this is also clearly visible on the breast CT. You see the large mass with the associated calcifications. You also see a sort of tail of non-mass enhancement. It was also visible on MRI. This was DCIS. And we saw an intramammary lymph node, which also appeared to be in the testicles, intramammary intestines. Case of mucinous carcinoma, visible on mammography and on ultrasound. And you see the enhancing mass on MRI and the tail of DCIS. And here you see the difference in contrast stages. On the MRI, the whole tumor enhances more or less the same, whereas on CT, you see that part of it enhances more than the rest. So it's like a different tumor, actually. And this is again the tail of DCIS. So that's due to the different contrast stages we use in MRI and CT. So they don't behave. So thus far we found that breast CT is highly sensitive for detection of mass lesion in the breast. It's also sensitive for detection of DCIS, and because of the enhancement, it may differentiate between benign and malignant calcifications. That would be a great step, because if you see them, they are probably benign, the calcifications, you don't have to do a biopsy. So that would save a lot of biopsies. But of course, this has to be proven in larger studies, but they're on the way. So it brings me to our indication for breast CT that may be different from your potential indications. But like Oliver said, we have in the Netherlands we have a population screening, but many women don't show up at population screening. It's free, it's supported by the government, but Many women don't show up because of pain, because of post-traumatic stress, and for them, actually, there is no alternative. MRI is too expensive, and the facility is too limited, and ultrasound is too insensitive. So otherwise they will not get screened. So that's why we offer them breast CT. And also in women who need an MRI, who have contraindications for MRI, we do the breast CT. Novel indications will be neoadjuvant chemotherapy, response monitoring. Also, probably, and that is would be a very nice indication, is screening in women with dense breast. For that, large studies need to be done. They will be done, but it takes some time. With contraindications for doing contrast-enhanced breast CT, of course, allergy to iodine contrast agents, patients with renal insufficiency, and if the patients are immovable and cannot do the work of 3 steps and lying from for the renal insufficiency, well, most women that have not been in the hospital or don't know they have renal insufficiency in the general population, then the chance that you have renal insufficiency is very, very low. So if there is no, so you can do a questionnaire if they have renal failure in the past, if they have diabetes, then we just can give IV contrast safely. And they know if they are allergic to iodine contrast. So the potential indication is the response monitoring after neoadjuvant chemotherapy. It's similar to MRI, so we are trying to replace all indications for MRI. And this is a one with 2 lesions, tumors in the left breast before neoadjuvant chemotherapy, and this is after courses of chemotherapy. You see, one tumor is gone, it does not enhance anymore, the other one is smaller. So that is what we see in tumor response. The tumor gets smaller and enhances less. Another case, 2 tumors in the right breast. Before neoadjuvant chemo and after, and you see there's only one left, and the other one doesn't enhance it anymore. That is also what we found on MRI. In this case, the woman with an enhancing tumor in the right breast. We do not do any needle localizations anymore, but we do marker localization with iodine, iodinated, it's radioactive iodine, or with a magnetic marker that the surgeon can detect during operation. So the iodine marker was inserted, and after the chemotherapy, you didn't see any enhancement of the tumor, and it was confirmed on MRI. So this is a complete response after the chemo. And also implants, so this is a mammogram with dense breast tissue, and this is how the implant looks on CT. You can see some folds in there. Some of them were really large. We can make volume renderings, but that's a nice image, but not diagnostic importance. And we can also visualize rupture. You see calcified breast with a calcified implant with the so-called wing sign we know from MRI, and a case of intracapsular rupture. But no indication. We can demonstrate leakage. This is a calcified calcified implant, and you see some material leaking out of the breast. So this is a leakage, the ruptures. The implant is the leakage. In another case, calcified leakage of silicon. As I said, we don't use we don't put localization of the hook wire localization. We don't use that anymore. We use the iodine reactive markers and magnetic markers. And we looked at the different markers, and this is the small titanium markers. We put it in the lesion after ultrasound biopsy. This is the iodine, the radioactive marker, and this is the magnetic marker. So you see the magnetic marker is much larger than the other ones. And they all give artifacts on the CT. But we have a software program that can remove these artifacts. Like you have also in a regular CT, you remove metallic artifacts and then you see the different markers in the reconstructed image. We also do that in patients. Here, this is the thin slice, the original thin slice with the marking. This is the magnetic marker, and you see it gives large artifacts. And when you apply the metallic artifact reduction technique, the artifacts are gone. And if you subtract these images, you get the size of the artifacts that's being removed. So in this patient, there was a tumor, and this is the small titanium marker from the ultrasound guided biopsy, and we put the metallic marker next to the marker, the titanium marker in the tumor. And in this way, it gives a nice pathway, a roadmap for the surgeon to locate the tumor during operation. In the case of localization in the patient with the microcalcifications, you see the iodine marker that gives artifacts which we can remove, and then you see the marker next to the calcifications, even lying against the calcification. So that's an elegant application of the technique. So what's in the future? Of course, we have about these CT-guided biopsy, and it looks as if we have to use a grid to localize the tumor. But another path that is being taken is to make newer and better reconstructions. And there must be artificial intelligence based, and that is to improve image quality, to make better reconstructions, faster reconstructions as well, and also to lower the dose, the radiation dose further. And we can also do a spectral CT that is actually measurement of the amount of iodine that is taken up by the tumor. We can also make virtual non-contrast images, so you can remove the contrast and you can make subtractions digitally. That was
Thank you so much, Dr. Wilson. Do we have questions from the audience? Are there images we want to relook at?
Thank you very much. I really like the images. My question is, all these images were lit images, so contrasted images. What are these lesions like? Like you're talking about the screening population. I'm sure you're not doing contrasted on the screening population, right? So what are these lesions and classifications like on the non-contrasted images?
Well, that depends on the amount of normal tissue that is there. So you really have to decide whether you get contrast or not. If you have a follow-up scan, then you can compare the previous one with the next one. So presented with the other one. It's possible to compare without contrast. But otherwise, you need contrast if there is, the breast is slightly
So
tender.
see and hear need contrast, even in the screening population.
Yeah, but we do, at the moment, because we are not allowed to do real screening, so we only screen the women that refuse to go to the ovulation screening. Because otherwise they would not get screened, so they would never have their breast examined. So this is the only way that we can image those women. And in those cases, if we know from possibly a previous mammogram if the breast is dense or not, and if in case we have no information on the density of the breast, we use contrast.
So it would be actually quite nice, this suggestion. Those that are recalled from screening, you get a contrast enhanced. I think that would be a nice way to go, isn't it? Another thing is probably, for the system-wise, how did you come up with the 70-second delay for contrast? It's a very specific number, isn't it?
It's more or less copied from the
CT.
Not from the CT, the regular CT, but from the breast, with the contrast enhanced mammography.
Because that's what, 2 minutes, right? Contrast enhanced mammography.
So we may make it
slightly less.
Experiment that we didn't have to wait so long. But
right.
It has not been figured out exactly how much you have to give and how long you have to wait. But it's still not completely.
Okay. Because it's a very specific number, so I was curious to find out. Thank you so much.
I see there's a discussion on that side. Is there something you would like to share? Gentleman with the grey shirt. Oh, you have a question here.
Thank you for the interesting presentation. Just have doubt here that for patients who refuse for mammograms, and if you would subject this patient for this CT, how would you characterize the shapes of microcalcifications on the CT? Because from what I see here, this shape isn't really crispy. So how do you go about that? Do you subject the patient to mammogram after the CT?
Well, if you give contrast and there is no enhancement, the chance of being a DCIS is pretty low. But still, it has to be proven. I agree with you. So then we do the biopsies, stereotactic, and look what's the result. But as far as we know, we haven't seen any case with the DCIS that is not enhanced, even grade 1 is enhanced.
Thank you very much. And I have another doubt here. Have you ever struggled with background parenchyma enhancement using the CT?
Yes, I showed you the image. It's really dense and a very high degree of background enhancement. It's getting difficult. So then you see that the sensitivity is getting lower. But it's almost 90%. It's still much better than
You want to go back to the image?
I can do that. That was the other presentation. My first. see the parenchymal enhancement not very pronounced. This is increasing the dense breast. But a little background enhancement. So the breast is dense tissue, but it doesn't enhance that much. So we would see an enhancing lesion pretty easily in this breast.
Thank you. And I have 2 more questions. Do you routinely do pre and post contrast for each patient, or it is just post contrast?
No, we only do, if we use contrast, we only do post contrast. We don't do the pre and post. It doesn't give you any additional information.
And my next question is, do you think that this CT will replace mammogram, because both are using radiation? So you see a role of this CT replacing mammogram in any time?
Yeah, well, it's part of the women. We have it already replaced because they don't want a mammogram. So we do it immediately. For the other women, it has to be remaining because we have, in a large portion of the women, we have to give contrast, and that's a threshold for large population or screening. So some part of the mammography will be replaced by breast CT, I'm sure about that. But first step is we want to replace MRI with breast CT, and then go forward to the mammography.
Thank you very much.
But I don't think it will totally replace mammography, because it's also more expensive than mammography. It's a matter of cost. It's also important.
Any thoughts you'd like to share?
The breast corners, is the size adjustable or is it standard size?
No, one size fits all.
Thank you.
So if you open the machine and you see through cylinder coming down, you see some lines where you can adjust the timing of the scanning. So women with small breasts, they will be maybe above the first line. Women with very big breasts will hang further down into the cylinder. If women would have really, really big breasts, you can actually have them wear either a sports bra without any metal or a t-shirt to make sure that the breast does not go further out of the cylinder that you see. Yeah? Any other questions? Yes.
Would that be a problem for the patient, because if the patient has very humongous breast, one will be inside the cup, one will be outside. The one, the breast that is outside, will it cause any difficulty to comfort?
Well, the breast has to be inside.
No, I think what he means is if a woman lies on the table and you put one breast in the cylinder and the other breast is really big, how would the positioning be for the patient? Will it be? And I suppose that has to do with the positions that we lie in. It's already slightly tilted. So the question. So if you lie in the machine, so let's say if the left breast needs to be scanned, you lie like this. So you're slightly, so you're not flat. And I suppose that's. Any other questions?
I noticed from the images, most of the axillary part is being cut off. You don't have a way, or are you planning opening up a bit the axilla?
Yeah, that's one of the things that maybe has to be changed, as you can see more of the axilla. Because the other system, the coding system, has a wider bore.
So you can actually get more.
Yeah, so maybe there has to be an extension to it that diameter, and if it does not fit in the tube, it's not imaged. That's good.
Anybody else? Questions, comments, slides you wish to see?
Hi, can I see the images? I'm interested in the images of the post-op of the residual disease.
Yes.
The other slides. Right. May I know what was the interval between the pre and post-op CT scan, CT breast?
It's a week or 2 weeks. Because the surgeon was not the surgeon could remove everything, and there were positive margins.
Yeah, okay. Because normally within like less than 1 month, normally we see the post-op changes. That's those 0-1 inflammatory changes.
Yeah.
But if we do MRI, it's very easy because we have other sequence like T2 and 3, which can tell me confidently say that those that enhancement is due to the inflammatory changes instead of the residual disease. So I'm interested how you can minimize all those inflammatory changes post-op.
Because we also see calcifications. They're also still there.
So this one is due to the calcifications.
Now it's due to the residual disease and additionally with calcifications. And so the surgeon did a reoperation. And what we did was residual disease. So it's always the combination between calcifications and enhancement. So indeed we were not sure it was only residual disease or that it may post-operative changes, but it turned out to be residual disease.
And in this case, the calcification you can see in the non-made images also?
Yes, well, it is a MIP, it's a thin slab MIP, so you can also MIP the individual slices with thinner and
on the presentation, I will continue the records. Right now is Q&A,
so these are
the streaming will be
images.
everything is working.
And then your experience is the classification is really easy, can see in a non-made, or it's equally easily can see both in non-made and made images?
Yeah, well, it's much easier on MIP images than on the individual side because the slices are so thin. They're 0.15 millimeters. You have no overview of what's coming above and below. So if you stack them, you have a better overview of the images.
Because I'm thinking, because a few literature said these are spread one normally will not enhance. And and then normally we see those dots look suspicious on the mammogram. We suggest 6 months follow-up, which is about 3. But in your case, if let's say you can't see any enhancement on CT breast, which I'm thinking like it's very difficult to see on, I mean, if it's not enhanced on CT, how are you going, how are we going to follow up those non-enhancing classifications, but it looks suspicious in distribution, especially those that group amorphous classifications?
Yeah, but there have not been large studies confirming that. So it's, but also in the Netherlands we're not going to operate DCIS grade 1. We just follow it up and then look if it gets more, and then there has to be an operation done. But we can follow it up.
So you do have a case that non-enhancing classification that's very easily picked up on CT?
Yes, we've settled on and that turned out not to be
in case that Dorsett enhanced initiative turn out to be benign and when we follow up it's growing?
Oh yeah, but that doesn't matter. Calcifications are not important. Calcifications are not the tumor. It's the product of the tumor. I have to visualize the tumor, not the product.
Right. Did that answer all your question? Is there anybody else who has a question who would like to see a repeat of something we have gone through already?
I'm just curious if we can still measure how still you live using this breast CT.
I agree.
That's all.
Your experience with using a CAs to enhance the reality, because you get them in MRI and contrast enhanced mammography and globular CAs. So, what is your experience with using?
I think it's the most tumor and lung carcinoma. And they have this one lung carcinoma.
So, even CT and globular.
Yeah, and this case I think that is related to the it's only one patient.
My concern is because you don't have morphology, so I think everyone is so used to having a mammogram, so I think that's why the question is, and you don't have that morphology, something that you're so used to that it kind of puts us into a panic mode. Yes, that's why I'll use numerous questions and small speculated lesions, small architectural distortions, so to say you see that there is a small focus of enhancement, in biopsy, sometimes you can see architectural distortions. Like just say we do contrast enhanced mammography, so we suddenly see a focus of enhancement, and then when we go back, we have our DBTs to compare. So when we could go to our DBT, and we're like, oh, we have this architectural distortion, and it's correlating. So those kind of cases, that's I'm kind of concerned about when it comes to just doing a CT without having the morphology.
On the mammography, because of the distortion, that's why you see the constellations. And on CT, because the morphology of the spatial resolution is so high, you can really see the morphology.
Do you have any such cases of the distortion of the small archy distortions that I can't see? That would be
if there is this tumor, because in many cases there is no tumor, and it needs to be a distortion, but it's we have cases in which there was a abnormality in mammography, so architectural morphology changes, but then there was no enhancement, and also a follow-up can go both ways. I think with breast CT, you really see the tumor. The same as MRI. MRI is superior to MRI. Has a very high sensitivity.
Thank you.
I've got a question for the doctors here on how do you get the other 50% or more for the Technorad or these statistics are that 50% and that's in Europe. I understand that the mortality rate is higher. So how do we make sort of progress in Malaysia to get more people going for this generation? Secondly, we had a presentation to HKN. HKN mentioned that they do the mammogram, and then if they have to do an MRI, there's a 3-month waiting list. There are 2 MRIs, one's taken up an hour, basically. 45 minutes to an hour. Half an hour. Okay. Is that because the contrast is less time?
I think yes, and that's why most of my already used to it.
Comparing speed, and we always talk about RMI and all these things. And just out of curiosity, we had one guy here before, Raymond just left. He's just set up in Japan, and he's an investor, and he's already going to go slow. They're going to start developing that manufacturing. He's hard, he's a Kiwi like himself, but he's been 35 years in Japan, and they have a lot of outlets. So he's putting 40 into his own facilities, just 40. So he's going to be starting off doing 100 a year. So the thing that's telling me already there's a massive demand. What I like about Malaysia is we've already got the NDA organized and certified, and we have a chunk of market. Nobody else in Southeast Asia has it. Korea has one, coming the second one, South Korea. No one else has it. Singapore's registered it, they're going after it. So personally, I'd love to see Malaysia be the first one to have it. And I hope that someone here, one of the hospitals do. And if not, at least if we get one here, we're going to invite you all to come and see that unit so you can test it and run through it. Yeah. Any questions from our team?
Yes, I'm going to stop in there. You can talk a lot. We have some slides on Phantom body that we did, and maybe Oliver can explain. This is from our presentation of Professor Schultz.
So, the credit to Professor Schultz. This is presentation, the part of it that he showed in the NCOR. Obviously, this is new modality. You need a new Phantom. How to do it? Is it? So, this Phantom was developed by one of our guys. You see some showing. This is not my presentation. The whole thing. That's the way it looks like. As you can see. One thing before, I forgot about to mention. It's very nice to see. Here's the mirror. Because we said no touching of the patient. By means of this mirror, you can position the patient in the right position. So here we see what this Phantom is introduced into the system. So we're looking at round lesions on soft tissue, microcalcifications. Just round lesions on soft tissue. On top we have the Phantom. Then we have the digital mammography. On the bottom line we have the new view. That's almost the Phantom. I think it speaks for themselves, and you can see that. Here we have the soft tissue. Top the Phantom, digital mammography, and then on the bottom the new view. And then have a look at the microcalcifications. Here it is an algorithm system, is a high resolution mode, what is taken. I think that's what we wanted to show to you. That's what the potential results and all the quality of images you can get or can get possibly. This is again, but this continues goes too far, otherwise I have to call a professor and he's traveling to Singapore on a bus. So thank you very much.
Thank you very much, and thank you very much, Dr. Martin Dorsett, for flying all the way to the Netherlands and giving us a user experience from the new view. We have our last guest. I would like to introduce Zalvinder Kaur, who will present on the latest technology of imaging. Sorry, I'm blocked by a very tall person. And Zalvinder Kaur is the CEO and co-founder of the Unsafe Solution, and I think a lot of people might already be familiar with her. Her company provides education for healthcare professionals and also offers solutions and services to address high cost and demand in the healthcare industry. She has about 30 years of experience in the radiography field and has been practicing 20 years in various hospitals. And the last 10 years, she is Successful People in Malaysia by the British Publishing House. And this year she is also received an award for women leadership by the CMO Globe. So I'd like to welcome her, not on stage, otherwise I can't see this presentation, on the latest technology community. Thank you.
Very good afternoon to all of you. Okay, to those who do not know me, you can call me. Some people call my name, you can call me SK. I always say not SK2, SK. I like that. Okay, so I'm going to share with you about the latest technology in imaging modalities. Knowing that Technorad, we used to go a lot of conferences and we felt that some of the technology that we should bring to Malaysia and getting consultation with our specialists, we consult them and say, yeah, this is the system to bring to Malaysia. So that's how we have, and I would like to share with you. Okay? So, again, you know all this, you have known clinical designation, digital memo, we know it's still active biopsy, DBT, tomo, contract, and today ABCT, yeah? So this is something really new, ABCT. And as Nazmi told us that we also do a memo system, okay, and that's called Viola DBT from Judo. So now why we go analog to digital, those who are not familiar with the memo, I'm sure most of you are, okay, but if you're not analog to digital, you all know because of the image quality, alright, okay, we all used to see really how digital image quality looks like everything looks okay, but you do not know that everything is overlapping, alright, so of course now the image quality is so much have been improved and give confidence to the radiologists, right? So effectiveness in detecting early disease depends on image quality, and I'm sure you all agree with that. Now, let's see, this was those images those days. Of course, you can magnify, you can see microcap, alright? You don't see so enhancing. These are CR images. Of course, now you have a VR images, which can highlight and see so much clearer. Okay, so I'm sure all of you have a VR now. Okay, and in fact, even fatty breast VR really helps. Here you look like in the CR image, you look like a subtle lesion, but of course when you zoom in and see in the digital system, it's definitely a speculated lesion. So even the fatty breast, VR really helps a lot. Okay, now going forward, what are the other challenges in mammography? Being a trainer, myself, training people with their machines and all that, there are a lot of limitations. You see, most of the systems think of image quality, right? For the radiologists. And who is producing this image quality? The poor radiographer. Alright, the poor radiographer is not getting all the nice things on breast coming, wow, you get the patient who also kyphotic, more breast, wheelchair patients, so many conditions, and stiff neck, frozen shoulder, every problem is there. Okay, but radiologist's concern is, you give me a profile of good, at least moderate, okay? And don't give me reasons. Alright, so and the poor radiographer has to do it. And the interesting part was, we have this they did not out of the box. Okay? I'm really impressed the way they think, because they think not only for the radiologists, they also thought of the radiographers, pain points, and they have this system that actually can incline. Okay, why is it really for to have the tilting movement? And it do especially with frozen shoulder and stiff neck, they are not able to push out, so you don't get a lot of muscle at the CCU. So today you have machine can go incline forward to enable to have the face inside, or if it's on a wheelchair, that's so much easier. We can do it on a wheelchair. And you know what? We used to force the patient to stand. We try to force them to stand. I'm sure you all are radiologists here, they know we have no choice, but usually sitting is not going to be nice at all. Okay, it's going to come in the way, you're going to get better muscle, patient is sitting, it's not comfortable. But today with the system going forward here, we are able to see the better muscle without pushing the patient back too much. Okay. So radiologists try to understand actually a lot of limitations, not only for radiology, even the machines, because when I work with their machine, some machines don't even pop up on the face of the moon. So that makes so difficult that the radiographer push the patient face away. The moment you push the patient face away, the pectoral muscle is gone. Alright? It's a very nice CC difficult, okay? So just sharing with you. Right, why does it turn this way? It makes you to do a probiopsy. Alright? See, you need another system, you need another room for probiopsy, you don't have that much money. Alright? To have another convenient room for you to have room. Here, you use the same machine that can do a normal memory, CSM, a tomo, and later you do a biopsy. Hey, why am I do a biopsy approved? I think that's the best way to go. Then I go for trainings and go see sites and then I do room, the patient do not at all. Except that little pinch there for local anesthesia. Okay? Now, if you say, how the machine goes, no, you can go like this. Only you like it. Alright? So, this is good, and after when you have this sort of system, you give this thing mobile, so you're able to push it anywhere near you or further than you. Okay? So, these are things that advancement in technology, which is really awesome, and leaders can put any way you like. Okay. It's the same that let us go to different. Okay, this is how it looks like. Right? So this is that patient is pro and the doctor has a side, you just do it here. Okay? So this is definitely the way to go forward. And I'm amazed with this. I don't know what else is. Okay? Now another thing is coming to Wolfara. Okay, Wolfara, people have heard about Wolfara, right? There's also Wolfara TMI. Okay, they have worked for over I think 10 years to make this more mature because why I'm not getting about some sort of at least TMI usually is very important because you know we are using something. Okay, but our goal is objective. You must have all these things to be seen. Okay, people profile, muscle to be seen, IMF to be seen. So this is something that in Australia now they are using is usually now they go to problem very so now they do a lot of this. They do extreme and now what does actually after the radiograph done a program, okay, so images will be later you can see the view meaning that you have a discussion on after you see I want to see how I perform for the day, how many cases done. I go into my SK and I put my password and I can see, oh, I only saw, I mean, this is a global year. In global rank-wise, I only got 2.2 points, which is not great. I've done 7 patients, and why over-compressed or under-compressed my patients? Okay, the system will let you know. So, no wonder whenever I do, okay, hey, you don't pay. No, my friend do always pay. Because I was under-compressing the patient. Alright, so I know, oh, I'm under-compressing my patient. No pay, still no pay. So I know that my friend is over-compressing. So we know where should our target compression should be. It gets, right? And not that. So he has a metric, remember, our goal out. Okay, you are doing objectively, but our goal out. Even if you must make sure that people are over and must be there. So these things come and like that. Not only that, they say, oh, I got 2 4, when did I come? And then I see here, I said, oh, 40%, moderate, not that great. And so I'm moderate, and then, oh my God, 70%. I'm shocked, that was good, you know? So what I do is I click on my moderate here, all the images are here. I know it's in my position, I know it's going to be one, it comes like the workstation, and it tells me where I go wrong. Hey, SK, you know what you're not getting educated to master, how many percent? 9% from the IMF. It's telling me that where I should be. Not only that, and how to improve myself. I'm not ego, I'm not my team first. So I can go there and click go there a bit more, and it will show me the view. Alright. Not only that, because she can also see all the radiographic what they're doing. I am not in my level, but my another girl is another radiography is another big head. So you need to change your knowledge and further improve your center. So that is the region. Now, so it's done, alright? ask ABC, ABC now. It's done now. Okay? Multiple we all know detector. We all know detector. Okay, right? So take a picture. Now, you also know what it was. Right? So basically, this is another thing. And we tell you have right? And mind is okay. So before we read about I'm sure many of you have seen people to work with this system. And first one, just you for one, still is under the table. Okay? And when it's all what is that is the tube is over under the wash. Okay? So now under wash means you have the eye up here and you are so comfortable. I was so comfortable with this system, you know, but nowadays they all have to move. But with this system you're only able to do you need another tube. Okay? So what the answer is, if this is under watch and I can see, I cannot do any extra. So I need additional tube, I need additional tube. Here and all that. So I need two tubes, one tube is another tube is for the X-ray. You need to be able okay, so another one is the O-cost tube. O-cost tube is the one they call meaning hey, I know you can go away, you don't need to be. Of course, if they don't swallow that, how we will give you the protection. Okay? Now let's see what Oprah Swiss will give you. Oprah Swiss will tell you so the label, all that you use to this overhead expression, particular marking which I was going the old way with the two detectors all this. So one system is called Oprah Suite. And what can this system do? So when you do of course, this one you will be set how you want into your room. And you do more than 200 meaning that you need and carry each to work in anything, your hand, everything works, right? Not only that, let's see how this works. It can go so low. Okay. You see it can go so low, it's a bit lower. Okay, now again, you can use the thing of when you fix the intelligence, whatever. Okay, children right on the detector, right on the thing, you know, like this is a camera that you down and really able to show standard logic. Also, right? It's a free program. You don't need to option, okay? And I'm sure you have many, but it's very good. Okay? If you have additional solely from the chart, you can do this way, this way away. And you can move away the grid, you can do directly and Okay? You can use your brand, and energy, which are also showing demo studies. Okay? So basically, this machine can do and use of application. Why is it important? So this is called class 3, alright? Let's go to the next thing. So basically, okay? So these are based in Malaysia. One is in South Korea. This week they have a winner equalization. Okay, because you cannot ada engine tak boleh ya, saya tak boleh lah. Okay, these are mostly that you don't do so much. Okay, like you mention alright, you can do that on the series. When all doing product. Okay, so I'm very good to do that. Really for something, but you do that as a business. So you cannot do that. Alright, so all now let's see this is like this. You see this energy. I put the blood energy. I'm sure I can. You are I have been very good. Okay, so those who are not familiar with blood energy is a very nice software, very good software. Two exposure, distribution, chest X-ray, kita akan cari nafas, tahan, tu exposure comes out, titik, nafas biasa. Itu je. You just the exposure, two energy comes out. One is 135 mAs and 80 kBs. So two exposure comes out, and you get 3 images. 3 images ini. One you don't have to get the conscious. The other one subtract the whole of the only see the soft tissue, and the other one is the wrist. Now, why is it important to see? Now, this is that you say you are able to do. Next. Yes, you will so what do you do? Those who can become your friends. This is or maybe oblique doctor. But most of it, I'm sure you all think of CT scan. If you're not wrong, okay? So maybe CT scan. And CT scan waiting time is sometimes take longer. In government, in private, I'm sure. So now, in this blood energy, when you take a picture, and first tahan, you get 3 images, and what you get is this one, and you get immediately another one. Oh, it's not in the lung. So when alright, so you say the CT scan, you say the dose, you say the anxiety position. If my dad was to go and do a chest X-ray and then they say there's some lesion there in CT scan, I would very worry, biopsy, so here you get to CT immediately. Okay? So how technology helps, right? You know, it helps to diagnose better and with the right diagnosis. Now, this one. This is the called RICS, right? The video oblique views. Okay? So oblique views is for RICS patient recovering from pain, and then they did a chest, they did an X-ray, and they did for RICS. So we magnify there was nothing. But when we get this side of energy, so when we magnify this image, and the same thing, can you see something there? Picture, right? Alright? So that's what the patient was complaining, because there's a lot of things overlapping and soft tissue and all that. So you are able to see the fracture over there. Okay? Although you don't do anything, I can't do anything, of course, but I know there's some fracture there, right? So patient can be, treated from it. Now, look at this case. Anything that you see here? Huh? Anything else? Looks okay, right? Okay, so then right, so let me answer. Looks alright here, but of course it is right, but if it has that energy here, we may see something different. Wow, what is this? seeing it. Correct? So I'm sure as a radiologist who is reporting the call, the radiologist, hey, tadi ada nampak tak patient ni bengkak mana? Betul? Oh, no, doctor, actually not lah, I'm not very sure. So there's so many patients, 100 patients. Then you call the patient maybe to feel that, you know. So but if you're reporting after working hours, how you know? Then at least you know, hey, there's something there. Because maybe patient come for some other thing. So here you know there's something, of course you bring to us, you need to refer to CT scan or chest radiation or something, right? So obviously the CT scan there is sufficient for that. But after the pre-op assessment, because they look then the next you can understand. But if you don't know, you don't have information, you only have report on the test. Right? So of course blood energy is so important. Like this vision, I said, I hope radiologists still do this one. Okay? I tell them what they said they tell the patient whether the patient change or not, they cannot touch the patient. Doesn't make sense, huh? So we should not have this immediate, but anyway, this is not talking about that. Now, blood energy, now you see a patient here. Is this going to be a rib or is it going to be a lung? So let's see, right? So obviously in this case it was a lung. Right, so if it's a lung, you can confirm the CT scan, right? And it was nothing injuries. Okay, that's how it shows. So little information, some of the places in Europe which they have some technology, they even use for screening, foreign worker screening. Okay, it has that, and most of the cases they use for oncology. Oncology because of the lesions, right? That's the idea. Now another thing is tomo. Wow, tomo in X-ray. We don't CT scan, we don't memo tomo. Actually, tomo sebenarnya dah lama sebenarnya. Okay, but many people, I think the tomo also, right? Okay. Dia tak pakai. Okay, actually there is tomo. Meaning that how does this tomo works? It goes a switch just like that. Okay, you tell the system you have to do tomo chest. So what happens? When you do that, the system, you position the patient, the machine will move up, and when you press the push button, it just moves one switch. Okay, you just switch one time, and you get the images, and you will record. So like you check if you can go on 10 mm or 5 mm. If you see something there, you want to go on 5 mm. So how does this help? Now you see here. In this digital radiograph, there is something there, right? Can you see that? Okay? So what happens is digital tomo macam ni, kadang-kadang macam ni. Ada coronal eh? You don't expect easier or what that? Coronal saja lah. So you get coronal images, and then you stop there where you think there is something there, and when you stop there, oh, there is something there, and then it was actually a irritating lesion. Right? Whether it was a post-infection or what, I'm not sure, but it was a lesion there. Okay? Now in this case, this patient has a tumor from the posterior to anterior. They want to check whether the anterior, the bronchus was affected or not. So when you get the bronchus, it's very fast. Like, okay, you do CT, CT is the way to go. But sometimes CT is so packed, so busy. So you can do things like this with the radiography system, right? So when you see here, okay, whether it's actually with the bronchus, you see, I think the bronchus is not suppressing on it. So the patient will actually for treatment. Okay, for this test. Okay, now any part, okay, even if it is joint. Actually, because macam-macam at night all jatuh problem, they come at night because the children back home, they bring the parents home to hospital at night, and you see a infection, but the patient is not able to turn the leg. So you don't know whether it's there or not. So you just go to home. You know, you see at least coronal card before you refer the patient for CT. Right? Actually, it's important for government hospital because CT is not easily accessible sometimes because unless it's trauma, brain, of course, okay, it's scaffold. Okay, give CT appointment, go straight away. And the private, of course, is they can do things compared to government. One of the more serious diseases. It's scaffold fracture. After you do the 4 views, then identification, optic, and then right? And then you see there's something there that you see in the scaphoid. Macam susah juga. Okay, maybe you can see. But now let's see in the tomo. Scaphoid tomo, you just do like this, the tube will just turn like this and take the images. So maybe you record it to a hand from here, and this is the images. So this is how it moves. Yeah. Yes. Yang mana tu yang biasa ni? Okay. Nampaklah tak tidak nampak tak? I don't know this. Very easy. After you see. Alright. Okay. After you go other parts, I'll just read some of the study that I have for you. Yeah. Okay. So you can see them or there's something there. Okay. So you are able to see things. Okay. Yeah. This is not only for this, but this is more important for us. like a spine. So like the spine, my patient is bleeding and you cannot ask a more view and all that. Of course, you got CT scan. Kalau kita tak ada CT scan itu, at least we can do this and see coronal side whether the patient have a fracture or perfect or whatever. Okay, so these are the things. So basically, why opera swing? Why you need an opera swing? Of course, now you see there are a lot of applications that you can do for radiology, especially your energy. Okay, you got tomosynthesis, so it can build your confidence more. Sometimes, after you say X-ray, just general X-ray, I know how to do. Of course, you don't know, but you can say that you need a CT scan and all that, right? Okay, so we can do procedure differently. Of course, there's radiation without compromising patient safety. Now, patient positioning and intention is very important. So without radiation emission, you can center because there is a camera there. As I told you, you can view it from your radiation room before you get exposed. But options for different mode because you know to have fluoroscopy, okay, fluoroscore and all that, and of course, easy visualization is also combination. Now, what about for the radiographers? In fact, I thought how am I going to teach the radiographers? It's just a one day. Everything is automated. Automated, easy to learn, that is simplified. In fact, even the memo machine, I was thinking, normally I teach some other brand when I was application for that. I think at least minimum 3 days to teach. But now I need half day to teach the memo machine. It's so easy, the user friendliness of the machine. Alright? So, quick learning curve, and for the radiographer 2-in-1 system, although for a lot of application, but it's honestly very simplified. You can always want to have a view, you can take you to sites. Okay, and you got all of this automation and APR and automation, of course, very important reject cases. So we always have to reject. I always say to bring into Malaysia, reject this is so important. You must have a reject list. So we have all that in place. And of course, objective this is your thing number. Mesti ada go to software. So the software is all in there. Okay, and in fact, I forgot to tell you, even the Viola GPT, the stereotactic biopsy, stereotactic biopsy, now they have the report on which nodule you take. Because we take core biopsy and we don't put markers. Some people do, but most of us, we take core biopsy pregnant guy, it will tell you, slide 1, which was coordination, and it's in the report. So this is a good, this is the latest thing that came out this year. Okay, so from biomedical part, okay, of course, let's issue only maintaining one detector, okay, and of course patient will be so much comfortable because they don't see the eye coming from the place like this, and the things are moving. The concept of GMN is patient should not move. They just try to take out the tube will move, means that the patient don't move at all. So that thing is really good, and many patients are happy about it. Okay, so okay, that's all. Any questions? No, we are all. No, actually the camera there are not the IT. So we are seeing all the time. Remember, we do something remotely, or when we are there, we see the patient. But when we are here, we have the camera, and we can see the patient also. But not AI. Purely on. Meaning that the patient moves, they move. No. No. I like that. I like that.
Your Ruparan BGMI and residency, you're familiar with the BGMI is new. Can it be applied to any system?
Yes, it's not vendor bias.
It's not vendor bias. And how do you charge for it? Do you charge for it per patient basis or you have to purchase the software?
Yeah, it's a yearly purchasing. Yearly. So that how many cases that you do, usually we have 3 systems, memo system. So you can connect to that same one software and you can get the result. So it is depend on how many cases that you do per year.
So it's per patient basis.
Yes, correct.
Thank you.
No, but of course,
AI, even though you say you pay per patient, but it kept it to like 200 patients. Then examination, more than 200 is different.
Yes, price. See, doctor, that's why I say that your sentence is 5,000 memo per year. Okay, last year was 4,000, this year assume 4,500, 10% or whatever. So we put maximum, so they can use it for online because there's a maximum check that you're putting. Of course, when you put, you say, hey, this was 6,000, but suddenly, so many patients are coming in, I don't know, we are having some campaign, then additionally you have to pay. Yeah. You always do more than that. Doctor, they just come into the assistant and computers in your place. Yes. I give you the link, your password and this one. So all the radiology, we did one test in HPI last time about this, so they have to access their own density. No, PGMI. Yeah. I think officer all there is going to be Shantani. So we did that. We did a test there, and then it was also mature. So we had a lot of good feedbacks from the team, And now I'm just asking my colleague, how are you using this? There are about 22 centers in Australia using it now, and they're from ready to get this. So it's getting more mature now, and it's something to guide you, and to tell you where you go wrong, where you stand, or else you don't know where, how to do the radiologists. So radiologists can see which, from Wapara is not only for PGMI, even the tools. Maybe this is one, machine satu, machine dua, machine tiga, right? You've got 3 machines there, they say line for different brand X, Y, and Z. They want to know whether the dose that they are getting is it correctly reported or not. Because this Wapara is non-mental bias. So they say I'm reporting only 1.2 milligray, the other machine is showing between 1.2 and 1.3, okay. But actually, here they showing 2.1 milligray, but the machine is showing 1.5, 1.6. Then you can ask the engineer, why is it so? Is it not calibrated? Because the Wapara doesn't track anyone, it's just not it is, you come, you pick me. So it's not mental bias, which is really important, and you are able to see where you stand actually. So radiologists also can see who are the surgeons or who are referring to them. Is it from the medical department or surgical department or the surgeon? A lot of data inside. For everyone there is a data. No. That's why it's the AI. Yeah. And actually I know PGMI, they are very good in I think now they are also yes, they will be transferred. Okay, but they use transfer AI from the Europe side. Okay, but not to the other side. If they ask in the tenders, that one, right? AI is location, but transfer, we have to get it like 2 years contract, apparently, we have to get for 2 years. Yes,
thank you very much, Leader, for nice, great sharing. Just wanted to check on the do you select your patients, or is it the automated like every program that we do? It goes through the PGMI software, because in PGMI you have exclusion criteria. Can you just explain a little bit of that?
Okay, so normally when you put understanding, it will go on, because if it's a single brand, it is not. Because PGMI is not but if it's a lumpectomy or mastectomy, it does not go automatically. So you can either manually push to the Wapara, or it will automatically. Just like they only want raw data. They don't want your process image, they only raw data. Okay, from the raw data is how they process to see whether you get PGMI. Okay, and your question was whether they want to push it or. So if they can choose auto push or the manual.
Yeah, because if manual can be, you can get tedious when you do a lot of patients in there. So obviously you want something friendly for the radiographers, and also you need to consider the exclusion criteria. So
I remember we did that, and I forgot what we said. It's for screening, and it also the private they were having to screen the part-time we did there in Macau. It was all for screening, then it automatically sent.
So far you have tested this in Pantai Hospital?
Pantai and HKL.
Yes,
it was one private government. Okay.
So the feedback was good?
HKL, they improved tremendously because they were getting a lot of over-exaggeration. So then they had to tell the surgeon and the radiologist, you should not do a CC over-exaggeration of this thing. You really need to do a proper CC to get a legal insight and as much as they can. So then they have changed, and then they saw the tremendous change from 40% of the good PG and Now the moderate became high. I mean, the PNG became high, 70% at the time. So they are planning to achieve okay, case.
So like what with auto pushers, all cases even if you stop everything.
Actually, it's not like it will not process those images that only a single breast.
So it actually decides for you.
But for the breast, for laparoscopy or I didn't forget for that. I will need to check.
So single breast, it will automatically decide that it's not going to do it.
Right.
Ni dah. Habis this
Any last questions for Sabrinda?
Habis ni semua baru saya start.
Okay. All right. Thank you very much, Sabrinda. Thank you very much for all our students for today. Thank you all very much for joining us here today. If you have any questions, we have lunchtime. There's food ready in a buffet. You know who the speakers are. Feel free to ask questions while they're eating. And we hope to see you again and have a great lunch. And thank you very much to the Technorad team for organizing this event. The lunch will